Okay, so we're going to finish up neuropsych this afternoon, second part of neuropsych. And when we left off on this slide, which I like this slide because it's a summary slide. It's one of these things that takes all sorts of disorders and kind of helps you clump them together. These are all things that cause pure motor weakness. There is nothing sensory in these things, okay? So it's a nice slide because if you have any of these things, you should have no sensory findings. Hypokalemic periodic paralysis, a channel problem, myasthenia, Lambert-Eaton, tic paralysis, botulism, certain toxins, those are all at the neuromuscular junction. Those all work at the neuromuscular junction. ALS, polio, West Nile virus, those are all kind of the anterior horn cells in the spinal cord, all right? But they're all, these are motor, not sensory findings here. Periodic paralysis. You get a 21-year-old Asian male, comes in your emergency department, been working out at the gym, comes in and says, I can't move my arms, I can't move my legs. You're like, seriously? Like, buck up, come on. How hard was that workout? Seriously, you can't move at all? That can't be right. So you figure, you know what, that's fine, I'll check some labs. Why not? Can't figure out what's going on with the guy. Potassium comes back, 1.6. Oops, sorry, my bad. Sorry, sir. You want a pillow, a blanket, bag, lunch, anything I can get for you there, that sort of thing, right? So, what is this about? Acute periodic paralysis. Like I described, classically young Asian male where there is a problem with their channels where potassium gets shifted into cells all of a sudden. Classically after exercise or after high carb meals, and I think about kind of like carb loading and exercise and that sort of thing going together. Also associated with thyrotoxicosis, so they can have hyperthyroidism, all right? So periodic paralysis, potassium shifts into cells, all of a sudden they're hypokalemic and they get very, very weak. And you're treating it, you replete their potassium, but remember their total body potassium isn't down, it's just hidden. So you're just kind of gentle as you're repleting their potassium. But that's periodic paralysis, a channel problem. Remember, Asian males, high carb, exercise, and hyperthyroidism. That would be a great exam question, the thyrotoxicosis. Myasthenia gravis. So just before we do myasthenia, a quick review of your neuromuscular junction. You got your nerve, right? And your nerve is kind of heading towards the neuromuscular junction. The nerve releases acetylcholine. The acetylcholine goes across that little no man's land, the synapse, right? And it lands on the muscle at the acetylcholine receptors there. So it releases the acetylcholine, goes across the synapse, it binds to those acetylcholine receptors and it makes the muscle twitch, right? And like when you're giving someone succinylcholine, it's going to those same acetylcholine receptors. That's the way things work at the neuromuscular junction. Well, myasthenia gravis, you've got an autoimmune disorder where you have antibodies against your acetylcholine receptor. So you're basically blocking those receptors, so you know you're going to be weak, right? Classically, young women, about a quarter have a thymoma, a tumor of the thymus where they're making the antibodies. Classically, bulbar weakness, ptosis, diplopia, basically bulbar weakness. And then you can also have some weakness of your arms and legs, more proximal than distal. But classically, it starts up in the face, all right? And the more you use it, the worse it is. You wake up in the morning, you're fine. By the end of the day, you've got ptosis. You start counting back 100, 99, 98, 97, 96, 95, 95. The more you use it, the worse it gets, all right? Repetitive use, you start using up that acetylcholine, it gets worse and worse. Precipitants, any acute thing, you don't have to remember it. So antibody against the acetylcholine receptor, weak around the face, arms as well, arms and legs as well, but mostly around the face. And the more you use it, the worse it gets. How do you make the diagnosis? You can send off blood for the antibodies. Look at the anti-acetylcholine receptor antibodies. So you can look for the antibodies. And then remember there's that tensilon test, the edrophonium test. Remember what tensilon does is it blocks acetylcholinesterase. Remember, acetylcholinesterase is hanging out in that synapse to eat up the leftover acetylcholine that's left over so it doesn't last forever, right? So if you use an enzyme, if you use a drug that blocks that esterase, the acetylcholine is going to last longer. It's going to stick around more, so you get more cholinergic transmission. So you take these patients, you put them on a monitor, you give them some of this edrophonium, this tensilon basically, and all of a sudden they get better transmission. They get better. Their face is doing better. Their ptosis is gone. Life is good, but it doesn't last that long. What is it, like 10, 15, 20 minutes, something like that. It's not long is the point, right? And all of a sudden they're back and they're weak again, all right? But it's a diagnostic test. Of course, if you get too much acetylcholine transmission, you can get cholinergic problems, right? Bradycardia, syncope, things like that. So they're always on a monitor when you're doing this test. Put them on a monitor, have some atropine at the bedside, give them a little tensilon, watch them get better. If you don't happen to have that sitting at the bedside drawer, your tensilon, okay, How about a glove filled with ice? That works too. So it turns out to take a glove, fill it up with ice, tie it up, and if they've got ptosis, you put that on their eye for a couple of minutes, and the cold actually improves neurologic transmission in this disorder as well. So actually, if that makes them better and they open their eye and they're like, ooh, it's doing better, it's open wider, that also is suggestive of myasthenia gravis, all right? Treating of this is basically longer acting tensilon, right? So instead of just doing it for a short amount, you're doing it for longer. So this is like physostigmine, neostigmine. They may take the thymus out. They may put them on autoimmune stuff, right? Like prednisone, plasmapheresis, things like that, all right? When people have myasthenia, they can come in really, really weak in respiratory distress, about to have a respiratory arrest, and that can happen from two different ways. One is what they call myasthenic crisis. It means their disease just got really bad, bad disease, and they're weak. The second is cholinergic crisis, meaning you gave them too much of their medicines, they have too much cholinergic transmission, and it's like that sludge syndrome stuff, right? They get too much cholinergic stuff going on, and they get weak from that, okay? So that's the two ways it can happen with myasthenia. Lambert-Eaton, if you had one thing to remember about this, just think it's kind of like myasthenia, but they probably got cancer, all right? Because about half the patients have cancer who've got this, so that means on the board exam, if they want you to go for Lambert-Eaton, probably somewhere in there, this patient has a history of cancer. But what happens here, it's also autoimmune. It blocks the release of the acetylcholine instead of the receptor, okay? And they also get weak, but instead of the face, it's mostly the extremities, and particularly walking up steps, getting out of a chair, kind of their thigh muscles are the big things that get really, really weak. And the other thing that's a little different is the more you use it, the stronger you get, not the weaker you get, like myasthenia, okay? But if you remember myasthenia with cancer, that's probably going to get you mostly there. If you can also remember that it's more thighs than the face, and it gets better with use instead of worse with use, that gets you all the way there, all right? But that's Lambert-Eaton syndrome. Botulism, another problem at the neuromuscular junction. You know Clostridium botulinum. It produces this heat labile toxin, so if it's got enough heat, you'll kill the thing off. But if not, you're going to make this toxin, right? And you remember there's three different types: foodborne, wound botulism, and infant botulism. All types of botulism, all three of them, same problem. You mess up your motor function, so they're weak, and it messes up autonomic function as well, okay? You have any cholinergic stuff, autonomic function. So weak and autonomic problems. So just kind of going back. So foodborne, you remember what this is from? This is like the 12-year-old can of beans, right? This is the person that had improperly cooked or, processed beans. They've been sitting around for a while. Those spores have started to germinate in there. And now when you eat the beans, you're actually eating the preformed toxin now. And you pretty quickly, like 12, 36 hours, something like that, start to get botulism. You get pretty sick. That's food botulism. Wound botulism is you've got the Clostridium living in a wound somewhere inside of you, right? So classic for this would be black tar heroin use, IV use, or skin popping, or things like that. Contaminated with Clostridium, it grows, it germinates, it makes the toxin inside your body, you get botulism, okay? Infantile botulism. Infant botulism it's an infant, it's a little kid who basically has ingested some stuff. A classic would be raw honey, but it doesn't have to be. There's lots of other things. Sometimes they don't even know why they got it. But they ingest the spores. In the infant's little belly, the spores starts to germinate, creates the toxin, and the infant gets botulism, all right? So you got your foodborne, your wound, and your infantile botulism. Symptoms, well, if it's foodborne, you get some GI stuff, right? Nausea, vomiting, diarrhea. And then basically all of them, because of this toxin working at the neuromuscular junction, gives you the bulbar symptoms. Blurry vision, almost always one of the first signs. Double vision, dysarthria, dysphagia, things like this. But you see, and ptosis. You see an intravenous drug user who comes in with some ptosis, I want you to think about botulism for sure, all right? That would be pretty good one for that. So bulbar system symptoms, and then descending flaccid paralysis. So it's kind of like the opposite of Guillain-Barré. Guillain-Barré works its way up and may have some sensory findings. This is pure motor, and it's all in the face and working its way down, descending flaccid paralysis. And then, of course, they also get anticholinergic symptoms, which I already told you about. You know anticholinergic stuff, big pupils, dry mouth, etc. Sensation is normal. This is a neuromuscular transmission problem. Infantile botulism, they also get weak, and they also get autonomic problems, but their weakness is basically floppy. They don't have not too much distance between their cranial nerves and the rest of their body, right? So they're just like floppy all over. Infants with botulism just have decreased tone all over, very, very floppy kid, okay? And their anticholinergic thing is essentially constipation. maybe a feeble cry, this sort of things because of weakness. But constipation, all right? So they're constipated and they're very, very floppy. That's infant botulism. So again, picture a really sad example. Kid, you can just see there's no tone at all in this kid's body. It didn't go from his little cranial nerves to his arms, that sort of thing. It's just floppy all over, infantile botulism. Treating it, they all get the antitoxin. If they've got botulism, you treat them with antitoxin, whether it's wound, foodborne, infant, doesn't matter. You got to give them the antitoxin. But if it's wound botulism, you also have to get rid of the contaminated stuff in the wound. So you debride the wound, and you give them some high-dose penicillin as well to kill off the Clostridium. All right? But they all get the antitoxin. That's the answer. Tick paralysis, you've got a little female tick that's living on you and sucking your blood and doing what ticks like to do. And in her salivary glands, this female egg-laden tick secretes a neurotoxin. Secretes a toxin that's very similar to Guillain-Barré, where it's ascending motor weakness, except no paresthesias. This is pure motor. This is another neuromuscular junction thing. Pure motor, ascending motor weakness, tick paralysis. To treat that, you got to get rid of the tick, all right? So you got to look closely, right? Because we see patients with weakness all the time in the ED, can't figure it out, what's going on with their legs or what's happening there. If they're, worried about ticks, got to look for the tick. It's easy to miss. Toxin neuropathies, this is just to remind you that lots of things can cause peripheral neuropathies, okay? Aminoglycosides, alcoholic peripheral neuropathy, things like that. You don't have to memorize a full-on list. Just remember there's lots of things that can cause painful and sensory and motor peripheral neuropathies. Okay, Wernicke's we talked about already, so I'm going to do it real quickly. That chronically malnourished alcoholic patient who has a thiamine B1 deficiency, the triad of altered mental status, ophthalmoplegia, and ataxia. You got to be really thoughtful about this diagnosis and treat them with thiamine. How much thiamine do we typically give someone when they come into ED and they're like their yellow bag or PO or whatever? How much do we give them? Maybe 100 milligrams. If you think someone's got Wernicke's, how much you want to give them? Like 500 milligrams 3 times a day for several days, all right? High dose thiamine. So what we give people is more like the preventive dose or the I'm getting you started on a little bit sort of dose. But if you really think someone's got Wernicke's, 500 3 times a day, big doses of thiamine is what you need to do, all right? It's about a 20% mortality. And of the people who do survive it, the vast majority of them will develop Korsakoff syndrome. Korsakoff syndrome is where folks have impaired memory, particularly difficulty learning new things and their more recent memory. So they'll remember their childhood and where they went to high school and where they went to college and things like that or whatever it was, but they don't remember what you just told them yesterday. All right? They don't remember any new information that you're telling them. And they do this thing called confabulation. Confabulation is where they essentially are making up memories to fill in the gaps that they have. And they're not fakers. They're not actually purposefully doing it. It's just the way their brain is working, that they can't remember. Like you say, what did you do yesterday? They can't remember, and their brain goes, I'll take it from this place. And they go, oh, yeah, I went out walking, I went shopping, went to Target, bought some this, bought some that, blah, blah, blah. They never left the house, okay? They're basically just filling in with confabulation, making in memories. And that's Korsakoff syndrome. Okay. West Nile, this is the bird-mosquito thing, right? So you get the mosquito, feeding on the crows, and then they finally think you're a crow, and they bite you, and now you've got West Nile. And again, I always say when you walk out in front of your house and you see like 20 dead crows, it's a bad omen, okay? I'm just telling you, all right? West Nile or not, it's not good, okay? This usually happens kind of like summer to early fall, usually around board review season is when I start hearing about the first cases of it, when we start doing the board review lectures and stuff like that. Not everyone who gets infected gets sick. Most of them who do get sick just have like a kind of flu-like sort of syndrome, right? Viral-like sort of syndrome. It's really the elderly that get the more severe disease, and it's only about 1% of patients that get the encephalitis and the problems at the spinal cord that Billy was talking about, transverse myelitis, problems with the anterior horn cells and things like that. So they can get encephalitis, but most don't. It's the elderly who get it. And after that, even as they're recovering, they can have flaccid paralysis because of these anterior horn cells involved, so that they're weak, basically this flaccid paralysis. It's one of the many viruses that can cause these post-viral paralyses going on there, okay? If you did an LP, there'd be some lymphocytes. They probably wouldn't ask you that one. And you're going to check the blood and the serum for the antibodies. It's supportive care. Okay, let's do seizures. And again, you see this all the time. Broad differential diagnosis, alcohol withdrawal, sedative withdrawal, CNS infection, lots of things. Don't forget about eclampsia. Had a case when I was a second-year resident. Thankfully, it wasn't mine, but a obese woman who came in status epilepticus. and they were doing the meds and the drugs and check the sugar and all that sort of stuff. And finally, like 30 minutes into this, the nurse said, I have the urine pregnancy test, and she's positive. Okay, and she was actually 3rd trimester pregnant and had eclampsia. So don't forget about eclampsia, and remember it can occur post-delivery as well. Let's see what else. Todd's paralysis. This is where somebody had a seizure, and they still have a refractory area of the brain. So maybe they're not moving their arm and leg or something like that, or not moving their arm, because that area of the brain is still refractory. Thrombolytics don't fix that, okay? So you got to take a seizure history when you're thinking, is this a stroke or is this just seizure? You got to take some good history. And you know this stuff, I think, so we'll do it real quick. You know, new onset seizures, they get some labs, maybe a head CT. Probably not an LP unless you're immunocompromised, you're looking real sick in front of you. But they get a labs and some head CT, and they get, you know, followed up as an outpatient. Chronic patients with seizures, it's basically checking their anticonvulsant levels if they're the ones that we usually check, unless there's something else new going on that day. But otherwise, it's checking their levels. Let's see. Oh, just the point in the bottom. Alcohol withdrawal, obviously you can treat with benzos. Benzodiazepines certainly work very well. You can treat with phenobarbital as well. But Dilantin, phenytoin, does not work for alcohol withdrawal seizures. So just to remind you, that does not work for alcohol withdrawal seizures. We see lots of alcoholics who are on Dilantin, but it's probably because they hit their head before and they got some encephalomalacia and they got a seizure disorder. But for alcohol withdrawal itself, phenytoin doesn't work. Just a quick reminder. And reminder, when we classify seizures, there's generalized or partial. Generalized means both hemispheres. Partial means it's partial. It's just part of the brain. It's focal seizure, right? Generalized seizures is 2 big types. There's the absence ones. Those are the kids that are just staring out. And there's the generalized tonic-clonic that we all see all the time. For focal seizures or partial seizures, they're either simple or complex. Simple means it's an area of the brain that doesn't affect your behavior. Here I am having a seizure, focal seizure, partial seizure. It's simple because I'm still talking to you. I'm thinking as clear as I usually do, all right? That's my focal seizure. But somebody who has something more like temporal lobe epilepsy, it's focal, but they're doing bizarre behavior, you know, and they're doing weird things, and they're walking around, or they're whatever it is. This is when people say, oh yeah, I was robbing the bank because of my seizures, okay? I didn't know what I was doing. That's all it was. But so those are focal, but those are partial complex seizures, not simple seizures, right? Treating seizures, again, you do this. Benzos, diazepam, lorazepam. You can use phenytoin. You can use phenobarbital. You can use Keppra. You can use, you know, there's lots of other agents that you can use. I will remind you that general anesthesia can work for seizures at some point as well, if you need to. Pseudo seizures. Hey, anybody ever seen one of these rare things? Pseudo seizures? Yeah, of course, right? So this is somebody faking a seizure, voluntary control. True story, I remember this one where I was called into the hallway for a patient who was having a seizure. Walked up and the guy was doing this sort of thing, and then he stopped, you know. And I walked up and put the rail up. And by the way, when you first get there, look and observe the seizure. Take in the beauty of the symmetry, right? Is it symmetric, or is there something focal here? Is there something actually going on in the brain? So it's important information. So you look at the seizure. So I walk up to him and I start talking to the guy. And this is like my new thing now, and I've been doing it. Actually, not new now. I do it all the time. Somebody has a seizure, and I'm not quite sure if they're having a seizure. I go up and I start talking to them afterwards, because what should they do? They'd be post-sick. They'll be right. They're altered. They're not going to have a full-on conversation with me. So this guy, you know, was flopping like a fish, stopped, and I walked up and I said to the nurse, I go, yeah, it looks like he had a seizure. I'm like, sir, are you okay? Are you doing all right? What happened? He's like, eyes closed, of course. Yeah, I'm all right. I just had a seizure, but I'm going to be okay. I'm just going to be post-ictal for a while. I swear. I said, okay, there you go. So that, my friends, that's a pseudo-seizure, all right? They're just faking it. Obviously, if you could do an EEG, nothing would be going on there. Status epilepticus, you're having a prolonged seizure, like 20, 30 minutes, or you're having multiple seizures where in between you're not coming back to your normal mental status baseline. Obviously, lots of things can do it. Don't forget about INH toxicity, which I know Billy mentioned in the tox section, I believe. So INH can do it. What is your antidote for that? B6. How much do you give? Lots. I like that answer. Right. What if you don't know how much they took? What do you start with? 5 grams. And if you know what they took? Gram for gram. Very good. Outstanding. Okay. What other things to just mention about status epilepticus? Oh, just the last bullet, just to remind you. I think you all know this, but just to remind you, just because intubate and paralyze somebody and it looks like they stopped seizing does not mean that they've actually stopped seizing, right? Just because you give them some rocuronium or vecuronium, it may look like they stopped, but you don't know. So you got to do EEG monitor on somebody you paralyze. And obviously try not to paralyze them if you can help it so you can follow it. Okay, let's do some spine stuff. Upper versus lower motor neurons. Upper, the brain, the spinal cord, everything going up into the anterior horn cells. Lower motor neurons are from the anterior horn cells all the way out to the peripheral nerve, right? And you know that's important because lesions in upper versus lower give you different symptoms. So upper give you things like increased tone, a hyperreflexia, clonus, Babinski sign, things like that, right? Those are the things that give you upper motor neuron sort of signs. Lower motor neuron signs are things like weakness, atrophy, fasciculations, hyporeflexia, right? Not hyperreflexia. So when you're examining somebody and there's something going on, say, hey, do I think this is upper, do I think this is lower? Now in ALS, amyotrophic lateral sclerosis, otherwise known as Lou Gehrig's disease, you actually have both upper and lower motor neurons involved. And that's one of the hints for diagnosing the disorder, okay? So this is a chronic deteriorating disease of neurons of both upper and lower motor neurons. They get difficulty eating, difficulty swallowing, problems with secretions, they get pneumonia, things like this, and unfortunately, it eventually leads to death. So you have upper motor findings like spasticity, right? Increased tone, that's upper thing, and then they have lower things like atrophy and fasciculations. Those are lower things. So you got both going in the same patient. That's one hint about ALS. Cauda equina, I know Billy touched on, so I'm just going to just repeat it for just a sec. You follow your spinal cord, you're going down, right, your spinal cord, where T12 and L1 meet, where you move from thoracic to lumbar. Your spinal cord turns into that little conus called the conus medullaris, and then beyond that, it's all these nerves, right? That's the cauda equina. There are a bunch of peripheral nerves that are still sitting within the spinal column, though. That's the cauda equina, and as Billy mentioned, you get compression, central disc herniation, tumors, fractures, epidurals, bleeds, whatever. Something compresses it, you get bad symptoms, you get incontinence, overflow incontinence, you get decreased rectal tone, you may have saddle anesthesia, where on the area where you'd sit on a saddle, like the perineum, you have decreased sensation. A great history question for that is when you wipe with toilet paper, does it feel normal or does it feel different, okay? Feel different, saddle anesthesia. Overflow incontinence, we talked about this sort of stuff. Hyporeflexia, motor loss. This is a surgical emergency, right? Because this peripheral root compression may be reversible. So you want imaging quickly and you want your spine surgeons involved early, basically. Okay, conus medullaris injury, similar presentation, not the exact presentation, but similar presentation, and some less recovery potential because it's actually the end of the cord, not just peripheral nerve. Epidurals, Billy talked about again, hematogenous spread, intravenous drug use, instrumentation. X-ray, no, that's probably not going to be positive for a while, right? Unless you've got an osteo going on for a couple of weeks. SED rate, CRP, yes, those are very helpful. MRI is the test that you want. Remember, you got to just be really thoughtful about this diagnosis because, as Billy mentioned, it is very easy to miss this one. If they come in fever, back pain, and weakness, you're probably not going to miss it. But early presentations, you got to be really careful. So anybody who's got intravenous drug use and comes in with back pain, man, I really almost always work them up with at least something. At least a SED rate or something like that. And if it's perfectly normal, again, if they got neuro findings or anything like that, they get an MRI. But if they just got this back pain, you can't perfectly explain it, and you're not quite ready to MRI on this moment, at least a SED rate is a minimum, and if that's at all abnormal, they got to get MRI'd. But have a low threshold for MRI. Lots of emergency physicians get sued for this one, and that doesn't mean that they were wrong, by the way, in missing it, because as Billy mentioned, it's something that can be easily missed when it first presents, but just really think about it. And I also agree with what Billy said, which is if you're going to do the MRI, just do all the levels. They'll oftentimes do kind of like the equivalent of a scout film through all the levels to figure out where they want to do more imaging on. But I've seen a number of epidurals where, yes, they also have it in the lumbar spine where you thought, but guess what? They got it in the cervical, they got it in the thoracic. Just buzz the whole thing. It's not time to save money on that MRI. Okay, and remember, folks who are intravenous drug users get at least 3 types of infections in their back. They can get an osteomyelitis, they can get a discitis, which is a disc space infection, and they can get an epidural abscess, right? So if we look at the x-ray here on this patient, let's start above the red circle, up here where it's nice and normal. Look at those nice, sharp ends of those bones, right? That's nice and normal. That's a really nice, normal space there. But if you look now, the one that's circled below it, you can see those same ends have been eaten away. So that person maybe started with a little disc space infection, like a discitis, that then extended into an osteomyelitis, which is why we're seeing it on X-ray. And who knows, they could have an epidural as well. We can't tell on X-ray, but these are the things you need to be looking out for. Extrinsic lesions, you can get cord compression from anything externally. I'm not going to give you a list. It's anything externally can do it. MR is what you want, of course, and you want to give them steroids, and you want prompt surgical consultation. That's pretty simple. Spinal cord compression, you know about that. Syrinx, syringomyelia. We don't see this very often at all, so let's spend a minute on it to remember. What this is a expanding central cavity in the spinal cord. It's like a lake of CSF that's growing and growing and growing. It can be anywhere in the cord, but usually, most commonly, it's in the cervical cord. It can be in other places, but usually it's in the cervical cord, which means for the boards, it's probably going to be in the cervical cord, all right, if it shows up on the boards. And because it's in your neck, in the cervical cord, you get arm symptoms. And what you get is weakness of your interossei muscle, okay, so they're not real strong anymore, weak in between your fingers there. And you get decreased pain and temperature in your hands. But the posterior functions, the vibration and position sense, is totally normal, okay? They call it sensory dissociation. So decreased pain and temperature, but normal position and vibration. I remember this by somebody smoking a cigarette. They're smoking a cigarette, and they're weak. They can't hold the cigarette real well because of the interossei muscle, and as it burns down to their fingers, they don't feel the pain and temperature, okay? That's the way I remember syrinx, syringomyelia. Loss of pain and temperature. It is associated with those Chiari defects, the things of the, where the low-hanging, the cerebellar tonsils, and they can kind of herniate down into the foramen magnum and plug up the fluid, and they think maybe that's why it backs up, okay? But bottom line is, collection of fluid in the middle of the cord, arm symptoms, remember the smoker, remember that sort of thing, and you'll get that right. Diagnosis by MRI. Treatment, I actually really don't know, okay? But that's not something I'm going to be treating, so I'm going to phone a friend. Let's do stroke. Let's see if we can get through stroke pretty quickly. Lots of questions you can ask about this. Bleeding strokes usually are hypertensive patients with small vessel bleeds down in the basal ganglia, right? And wherever they bleed is where they get their symptoms, right? Whatever, if it's a cerebellum, they get cerebellar sort of stuff. That makes sense. You know that when somebody's got a hemorrhagic stroke, we want to control their blood pressure. What we don't know is what the really best goals are for blood pressure control. The general rule is we want to bring it down some, but not too much. There's not a great answer for this, right? But you want to use things like labetalol or maybe nicardipine, but not nitroprusside because it will give you increased ICP. But you give them a little bit of labetalol, bring down their MAP, 10, 20%, something like that. But you're trying to bring them down without stroking them out by bringing it down too far, right? But that's your intracerebral bleeds. Hemorrhagic stroke, again, you see some of the ventricles there where the arrows are. That's just hemorrhagic bleeds. More intraventricular hemorrhage, you see some layering in the posterior horn there of the lateral ventricle. Okay, some kind of just general rules that will help you with exam questions and with patients. When you have a cortical stroke, that is the cortex, those are the things that give you numb and weak on the opposite face, arm, and leg, okay? So if you got the stroke on the right cortex, you're numb and weak on the left face, arm, and leg. That's a cortical stroke. If you're numb on one side of your face, but the other side, arm and leg, that's the brainstem, okay? Because you're basically got crossing stuff going on there, all right? So if you got the right side of the face, but the left arm and leg, that's not the cortex, that's the brainstem, all right? The other thing to know is you just got to know this one. Pontine hemorrhage, pontine strokes, coma, and small pupils. It's going to be this person who comes in, maybe hypertensive, maybe not, small pupils, coma. You're giving them lots of Narcan. It's not doing anything because it's not an opiate, all right? Pontine hemorrhage, pontine strokes, coma, and small pupils. That could show up. It's pretty classic. And then, of course, cerebellar strokes, ataxia, nausea, vomiting, that sort of stuff. Okay, I'd like to really quickly go over the anatomy. And I know this stuff is painful. I'm honestly not very good at anatomy at all. But if you know the blood flow to the brain, it'll help you with some of the strokes. And it's not that hard, honestly. So the first thing, as we look at this slide, I want you to think about drawing a line. See where it says posterior communicating? See that there? Imagine if you drew a line straight across there. Okay? Just kind of extended that line horizontally. That would separate your anterior circulation, which is all this stuff up here, from your posterior circulation, which is all the stuff down here. Does that make sense? Okay. Let's go through the tracing real quickly. Anterior circulation, pretty simple. Anterior of your neck, right? What's that? Carotid artery, internal carotid. So here it is, the anterior circulation, the anterior of your neck is the internal carotid. It goes up and it splits into the middle cerebral and the anterior cerebral. Those are the ones you got to remember. Anterior cerebral artery, middle cerebral artery. And when you get strokes in there, you get numb and weak on the opposite side. Pretty simple. Anterior circulation strokes. Posterior circulation starts posteriorly, the back of your neck, your vertebral arteries in the bottom there, at the back of your neck, down at the bottom of the slide. 2 vertebral arteries, there they are, 1, 2. They start going north and they fuse to make the basilar, see it says basilar, the basilar artery there. Off of that basilar artery, you get lots of little branches. They go to your brainstem, they go to your cerebellum. You're not going to memorize them for the EM boards. Don't bother. If you're a neurologist, you need to know them. We don't need to know every little one of them, all right? So the basilar artery, things go to the cerebellum, things go to the brainstem. Then you follow that basilar artery all the way up to the base of the skull, to the base of the brain now. Here we go. We're going north again. Going north, and now it splits, left and right. So it goes into the posterior cerebral arteries, going to the back of the cerebrum, the back of the brain. And that's your visual cortex, right? So strokes there cause you blindness on one side, that sort of thing, right? Homonymous hemianopsia, we'll talk about that. So anterior circulation and posterior circulation. That's pretty simple. Anterior circulation strokes. There's the anterior cerebral artery. If you knock that one out, you get numb and weak on the opposite side, but it's mostly your leg. You could have a little arm and face, I guess, but it's mostly leg. So they have gait problems because their leg's weak. So they're numb and weak in their leg. So ACA, which is the less common one, as you can see, it's leg, it's gait disturbance. Middle cerebral arteries, which we see all the time, MCA strokes, right? They're numb and weak more in their face and arm more than leg. But it can be all, right? It can be face, arm, and leg. But as a general rule, more face and arm than leg. And again, these are generalizations. As you know, patients can present very differently with these syndromes. But in general, MCA stroke is more face and arm more than leg, maybe, okay? In addition, you get some other stuff. Remember your optic radiations going from your eyeball to your occipital cortex? All those radiations going back to bring the vision, the images to your back of your brain? Well, if you get the middle cerebral, it's the middle of your brain. It knocks out all those things. It cuts them. So you get a homonymous hemianopsia, which means you don't see the opposite side of the room in each eye. So for example, if I get a right MCA stroke, I lose the left side of the room. I lose the left side in this eye, kind of, laterally there. And I lose the left side in this eye, which would be the nasal side over here, right? I'm losing the left on everything. So if my right stroke, I'm weak and numb on my left side, and I lose the vision on that left side of the room as well. Okay, does that make sense? Homonymous hemianopsia. And then if it's your dominant hemisphere, which for most people, because most people are right-handed, it's your left, right? So if it's your left hemisphere, your dominant hemisphere, you'll have aphasia. You don't talk, you're not talking. If it's your non-dominant hemisphere, you get hemi-neglect, where you just neglect that opposite side of your body, okay? So kind of summary here. I get a left MCA stroke. My left MCA means I'm going to be numb and weak on my right face, arm, and leg. More face and arm than leg, okay? I'm going to be numb on the right and weak on the right. I'm not going to see the right side of the room in either one of my eyes, okay? And because it's my dominant hemisphere, I'll have aphasia. If I get a right MCA stroke, I'm numb and weak on my left face, arm, and leg. Face and arm more than leg. I'm also blind on my left side. That is the left side of the room I don't see out of either eye. And because it's my non-dominant hemisphere, I just have hemi-neglect of that left side of my body, the same one that's numb and weak. I don't dress it. I don't put makeup on that side of the face, that sort of stuff. You neglect that side, okay? So those are your MCA strokes. Posterior cerebral artery, I already told you, that's visual cortex. So if you knock out the one on the right, you get a left homonymous hemianopsia. If I knock out the one on the left, I get a right homonymous hemianopsia. If I knock out both PCAs, that's cortical blindness. You can't see on either side. And that'll happen after CPR. You get somebody who comes in, ER, CPR, you get them back, but they were down for a while. It's kind of a watershed area of the brain, so they can stroke out on both sides, and they can end up waking up at being blind post their CPR. All right? That's posterior cerebral artery stroke. Then there's that vertebrobasilar artery, that darn thing with all the branches to this brainstem and the cerebellum and things like that. It just gives you brainstemmy, cerebellary sort of things, right? Vertigo, syncope, nystagmus, dysarthria, cranial nerve sort of things, right? Brainstem sort of things. That's pretty easy. That's just making it simple. That's the only level we need for this test. There's a couple of syndromes here. Forget the top one. It's complex. I don't think you need to memorize the syndrome per se. It's just an example of where you're numb and weak on one side of the face and the opposite side of the body, and it just tells you it's brainstem. Don't spend too much time on that. Locked-in syndrome, remember that was central pontine myelinolysis. When you have hyponatremia and you fix it too quickly, you get central pontine myelinolysis. You get locked-in syndrome. These people can't move, they can't talk. The only thing they can do is vertical eye movements. But they're awake, they're alert, they hear you, they feel things, they sleep, they're normal. It's almost like being paralyzed with vecuronium, but you're breathing on your own, and the only thing you got left is vertical eye movements, okay? Really horrible thing to get, which is why you really got to treat that low sodium slowly, okay? We don't want that one. That's locked-in syndrome. So it can be seen with basilar artery occlusion at the pons. It can be also seen with the central pontine myelinolysis. So you've messed up your pons, you can get locked-in syndrome. Okay, cerebellar infarct, it's a stroke in the cerebellum. No big surprise there of what's going on. Nausea, vomiting, ataxia. Just one thing to remind you of, that it's a very small space in the posterior fossa. So when they get edema, and it's particularly if they bleed into their posterior fossa, they can go down the hill, down the tubes really fast. So watch them really closely. Lacunar infarcts, these are just, I showed you all the big vessels. These are all the little vessels, the little ones that I didn't show you, the deep penetrating vessels, okay? That they get these little small, very focal strokes, and they tend to have a better prognosis than the large vessel strokes. There's a bunch of different types. I don't think you have to memorize all the different types. Some of these are just for example. So like, if I were weak on my left, face and arm and leg and things like that, how did that happen? How did I get weaker, hemiparesis on my left side, with no sensory finding at all? That's not the cortex. Well, internal capsule. Or how if I'm just numb on one side and motor's normal? Well, thalamus, lacunar infarctions, okay? So smaller, more focal infarctions, and you'll see those things on head CT as well, like that, right? See where the arrow's pointing? That little hole, piece of Swiss cheese hole that's left there? That's an old lacunar infarction. Obviously, acutely you don't see it, but later it gets eaten away when those cells die off. So those are old, deep lacunar infarctions, small vessel infarctions. Treating stroke, make sure it's a stroke, not a Todd's paralysis or a tumor or hypoglycemia or Bell's palsy. CT to rule out bleed, aspirin if you're not giving them thrombolytics and they're not bleeding. Blood pressure, you generally kind of want to leave it alone unless it's really high. I don't know what the exact number is, 225 over, 150 something? I don't know, high, basically high numbers, 160 something, high, 180, what am I saying, 150, like 185, like high numbers. Leave it alone for the most part. Ischemic strokes, mostly leave it alone unless the number really scares you really, really high. And when you start to lower it slowly so that you don't stroke them out, all right? But for the most part, it's just an automatic reflex. It's part of the brain trying to preserve its cerebral perfusion pressure. Leave it alone. If they're hyperglycemic, give them some insulin to get their sugar down. Don't give them hypotonic fluid so they don't get brain edema. This is kind of basic stuff, right? Thrombolytics are for ischemic strokes with a significant deficit, so they're not just like numb on their lip or something like that, because there's risk associated with it. They're not clearly rapidly improving like a big TIA that's clearly rapidly improving. And time from last known normal to drug on board, less than 4.5 hours, okay? There's always been controversy in the EM community about thrombolytics and do we do it and what's the window and the whole thing. They're not going to try to trick you on the boards, okay? If they give you someone with an ischemic stroke who doesn't have any other contraindication, which are these bleeding risks, like they're on Coumadin and their INR is over, 1.7, or they have a known aneurysm or AVM or things like this, then just go ahead and give it if they're within that time window between, last known normal, 4.5 hours. You want their blood pressure below 185 over 110. I don't know why that blood pressure number is not sticking in my head while I'm sitting up here. I was going to talk to you about stroke, but sorry. Okay, little neurology trivia, and then we'll move on to some psych stuff. Uncal herniation, this is where the person, they're about to herniate in front of you. They're herniating. They get this one dilated pupil, right? They get this one, fixed dilated pupil. That's pretty bad. That's herniation. That patient is sick. What about the patient who Paramedics call in. They say, yeah, a patient was assaulted multiple times with fists to the face. They got a dilated right pupil. One dilated pupil, it's not very reactive, and their GCS is 15. We're bringing them code 3 because we think they might be herniating. Are they herniating? No. What happened to their eye? Traumatic mydriasis. They just got popped in the eye and a little spasm there, right? So they get traumatic mydriasis. So these patients with herniation, they look like they're herniating. They don't look like they're awake, or they just got, scopolamine in their eye or things like that, all right? Cushing's reflex, somebody's about to herniate, and basically it's a dysregulation of what blood flow to the brain. So what happens is their ICP is going up. It's going up, it's going up, it's going up, and their body says, oh my God, we need some blood flow to this brain. Our ICP is too high. So they get hypertensive so they can bring blood flow up. But as the blood is flowing up, the carotid bodies say, whoa, hey there, fella, that's a lot of blood flow to the brain. Let me slow you down. Let me make you bradycardic, okay? It's just totally dysregulation. So they're hypertensive and bradycardic, and that's Cushing's reflex. And again, impending herniation. These are sick patients, not well-appearing patients with hypertension and on beta blockers, all right? They're looking sick. Stroke versus seizure. Where do the eyeballs go? So the frontal eye fields push your eyes. So if I have a stroke in the right frontal eye field, I've taken out that eye field, I'm going to look towards the stroke because I lost the push. I took out the push, and I look towards the stroke. If I have a seizure, my push area is seizing and activating, and it pushes you away, okay? So your seizures, you look away from the focus, and with stroke, you look towards the focus. There you go. Ophthalmoplegic migraine is just to remind you that some patients with migraines will also have cranial nerve deficits associated with it, 3, 4, 6, ocular motor sort of palsies, things like this going on, ocular findings. Just make sure it really is a migraine before you call it that, all right? That's it. Headache upon awakening usually just means you got increased intracranial pressure, which means it's usually bad, okay? Unlike the post-LP headache, remember the post-LP headache, post-dural puncture headache is worse when they sit up. Think of it as like their tank is empty and you sit them up and now it's even more empty. Bad, bad headache. With things that are worse in the morning, it's because you've got increased ICP, pseudotumor, tumors, things like that. Okay, you're working in a small ED in the middle of nowhere, and this patient comes in and they're going down in front of you and they got a blown pupil, and your neurosurgeon says, you've got to drill a burr hole. And you're like, seriously? And they say, yes, because it's the boards and we're going to make you do it, okay? And they say, we're going to drill the burr hole. And you say, can you get here soon? And they say, yes, in an hour again, okay? So which side do you want to drill the burr hole on, the left or the right? What do we think? It's Vegas, 50-50. Come on, you're not going to get better odds than this. Where do you want to go? Let's go on the right. Let's go where the blown pupil is. It's not always on that side, but if you're not sure, your CT was down, by the way, too, all right? So you couldn't even tell what side it was on, right? Yeah, it's most likely on the same side as a blown pupil. That's where you would go. Okay, myopathy versus neuropathy. Myopathy, right, muscle problem, neuropathy, nerve problem. Myopathy is going to give you proximal weakness versus neuropathy, distal weakness. So with myopathies, it's more like shoulders and thighs. With neuropathy, it's like the hand grip. And of course, neuropathies can have sensory findings as well. So that's telling you your myopathy versus neuropathy. Unexplained syncope, one of the things to have in your differential is vertebrobasilar insufficiency, right? So remember the stuff going to the brainstem, those little posterior branches going to the brainstem. Older patients got some atherosclerosis there. They could just be getting syncope from that. So vertebrobasilar insufficiency. Phenytoin, obviously you can use it for seizures, but it also actually is an antiarrhythmic, and so it can worsen heart block. So if somebody's in second-degree heart block or third-degree heart block, you do not want to give them phenytoin. Fun facts for the whole family. All right, there you go. We already talked about pontine hemorrhage is that coma and small pupils, so you'll remember that one. Complex regional pain syndrome 1. This used to be called reflex sympathetic dystrophy. Remember this one? Someone gets injured, they get some trauma, let's say to an extremity or something like that, they get an injury. And then after that, after the initial injury, they have, horrible, horrible pain. It's almost like the phantom limb pain. This pain that's going on there, burning pain, hyperalgesia. You touch it and it's just really, really, it's the skin, really, really burning pain. If you took an x-ray, they actually may have osteopenia. They can get skin changes, sweating changes. Their skin can be pale. It can be a little red. So this is a real thing. These, again, are not fakers. This is an injury where it affects your sympathetic flow, and they get osteopenia and all these bad things. Lots of different treatments, ganglion blocks, beer blocks, gabapentin, right? Lots of things that you can use for that. Okay, let's do a little psych with our last bit of time here. Another mnemonic for mental status exam, if you like it. I don't personally use it, but we put it there for folks who like those sort of mnemonics. As always, before you call something psychiatric, rule out organic illness. Functional, meaning psychiatric, versus organic. You could definitely write exam questions about this, and again, I think you know this stuff. Functional or psychiatric disorders tend to be younger patients, 15 to 40, versus, organic, they're either real young or they're older. I'm not calling that old, by the way, because I'm in that category. They're just older than the ones more likely to have the psychiatric runs, right? So the idea is if you have a 75-year-old woman who comes on with new onset hallucinations, it's probably not schizophrenia, right? It's something organic going on with that person. And then as far as hallucinations, you remember that auditory is more likely psychiatric, and visual or tactile is most likely organic, okay? Sensorium in patients who have psych disorders may be clear, so they may know where they are, and they may know the year and be oriented and things like that, right? They just think the FBI is shooting laser beams at them from outer space, right? But they know where they are. Versus, organic, this is altered mental status. These are confused patients who have delirium, that sort of stuff going on, okay? And they may have other hints like abnormal vitals and big pupils and syndromes and things like that, all right? Functional versus organic, definitely testable stuff. Amnesia, okay. Yeah, what was I going to say? That's my dad joke. My kids do not think I'm funny at all, by the way, and they're right. But anyway, dad joke. So impaired memory, right? We talked about Wernicke's. I won't do it again. TGA, transient global amnesia. People just can't seem to form new memories, but only for like 6 to 24 hours, and then they get better. We don't know what causes it. Traumatic amnesia, you know about this all the time, right? People bonk their head, and now they're like, dude, what happened? And you tell them what happened, and they're like, huh, dude, what happened? And like repeat that over and over and over. Also very popular on soap operas, by the way. That's an independent risk factor. If you're on a soap opera, you get traumatic amnesia. So that's amnesia. Anorexia, very serious disorder, obviously eating disorder, young women, distorted body image, so they're not eating, they feel that they are obese, and you're looking at them, and obviously they're very, very, very thin and underweight, lots of morbidity and mortality that can happen with this, so we really need to be on the eye, keep an eye out for this and make sure that we're getting referrals for these young women. Antisocial personality. Okay, if you don't work in an ER, you don't see antisocial personality disorder because this is like our bread and butter, right? I mean, antisocial personality disorder, these are the young patients doing things they shouldn't have done. They're running from the police. They're robbing people. They're breaking the rules. They're jumping over things and getting calcaneus fractures, all that sort of thing. So they are disrespecting the rights of others. They are disrespecting the law. They're not behaving very nicely, very impulsive behavior in these younger patients, oftentimes male patients. Also may have substance abuse. Good news is as they get older, tends to get better. So hey, I'm kind of a glass half full sort of guy, all right? There you go. That's antisocial personality. Borderline personality disorder is really interesting, and this is actually pretty common in the US. It's not that uncommon. These folks have a lot of emotional lability, and they have very intense relationships, unstable relationships, right? Things are going great, and then things are going bad, and they do this thing called splitting, where I love this person and I hate this person, or this therapist of mine is great. This one I don't want to see them ever again. They're horrible. It's this kind of splitting thing they do. These very intense interpersonal relationships that are very, very unstable. They can have suicide gestures and threats as well, and actual attempts as well. It's really interesting, borderline personality disorder, because there are neuroses and there are psychoses, right? Neuroses are like, your usual personality disorders. Psychoses, that's right, like schizophrenia and bipolar disorder and things like that. Borderline personality disorder is called borderline because they live in the borderline between the neuroses and the psychoses. The vast majority of the time, they're actually living in the neuroses. They have the neuroses part, which is the personality disorder with the unstable relationships that I was just talking about. But they can have this thing called brief micropsychosis, where briefly they actually cross over into the psychotic. They can have persecutory delusions. They can have depersonalization, where they feel like they're out of their body. Things like that. They can have hypochondriasis, where they're really preoccupied with being sick. So they can actually move briefly into the psychotic, and then they move back into the neurotic again. And that's why it's called borderline personality disorder. Actually pretty common. Histrionic, so this is the emotional, dramatic, extroverted, attention-seeking behavior. Very seductive, impulsive behavior. Here the suicide is more gestures than like the solid attempts, right? So they're not taking a whole bunch of tricyclics. Maybe it's like Motrin and Bactrim or something like that going on here, right? It's more the attention-seeking behavior. They do not get micropsychosis or things like that. That's histrionic personality disorder. Narcissistic personality disorder, I think we've all seen this one. Exaggerated sense of self-abilities and achievement. This is somebody who just really thinks it's all about them, right? I'm sure you've seen folks like this. Exaggerated sense of self-importance. It's all about them. They can do anything that they want. I can play center for a professional football team or something like that. Yeah, not going to happen, right? I'm going to get crushed like a little peanut, right? So that's not going to happen, right? But this kind of unrealistic expectations and ambitions, and really not a lot of empathy for people around them. They're really much more concerned about themselves. Narcissistic personality disorder. Anxiety disorders, very common, lots of different ones, tend to be younger patients, oftentimes autonomic hyperactivity, right? They look anxious. You know what it looks like. They're maybe sweating, maybe a little, just like increased motor activity. They're pacing at the end of the gurney or something like that. Those are your anxiety disorders. There's lots of different types of anxiety disorders. PTSD, of course, we're familiar with, post-traumatic stress disorder. This is where somebody's had some sort of a very serious trauma that's gone on in their life. Classically, it would be someone coming back from combat, but it can be other sorts of very serious traumas that people have as well that can cause post-traumatic stress disorder. So now they have continued anxiety. So it's not just the event that was then traumatic, it's that they relive and continue to experience the severe anxiety as a result of that horrible traumatic event. And of course, it's associated with substance use disorders. It's associated with suicidality as well. So this is one of the really sad things that our veterans get when they come back from combat. Really sad, PTSD. Panic attack. As you know, these are patients who get intense, incredible anxiety that tends to come out of nowhere. And you remember patients with agoraphobia who don't want to leave the house, that sort of thing? One of the reasons they don't want to leave the house is that they oftentimes have panic attacks. And they're totally afraid of being out like at the market and just totally losing it, having severe anxiety just out of nowhere. So they're like, I feel better just staying in the house, right? I get too much anxiety. So panic attack, severe anxiety coming out of nowhere. OCD, obsessive compulsive disorder. Remember that obsessions are repetitive, unwanted thoughts, whereas compulsions are repetitive, unwanted actions or behaviors. So an obsession is, I keep thinking, did I close the garage door? I keep wondering about that, or I keep thinking about this thing. A compulsion is, I keep washing my hands over and over, those sort of things, something I keep doing. And folks with OCD, they oftentimes have what they call rituals, right? Ritualistic behavior. They say, okay, I'm going to put this here, okay, put that there, this thing there, okay. Now I'm ready to go to bed, or now I'm ready to whatever, right? And basically it's a way of managing their anxiety. It makes them feel better that if they go through their ritual and do their thing, it's a way that they can kind of manage their anxiety. So that's obsessive compulsive disorder. And then phobias are just really severe fears that, for example, you're afraid of snakes. You see that snake, oh my God, severe panic based on that. Those are just severe fears. Bipolar disorder, you know about. This is manic depressive illness. Young patients usually starts in their 20s. That's what that means by the third decade, right, is your 20s if you do the math. There's family history, and you know what they look like, right? These patients, when they're manic stage, they're very, very elevated. Tangential thoughts, flight of ideas, pressured speech. They're staying up all night, hypergraphia, very flamboyant dress, hypersexual, and you're talking to them, and it's almost like funny as you're talking, right? Because you're talking to them, and they're so elevated, and you walk away, and you're like, oh my God, that was a really interesting history. And it's not that you're making fun of the patient, because we don't make fun of our patients, but it's when you feel that elevation of mood, it's actually part of the diagnostic test, where you're like, I wonder if that person's manic, because that was like a really elevated conversation. So when you find your own kind of natural human instinct is smiling and that sort of thing, right? You want to think about, is that what's going on? This person could be in a manic state. And of course, they have severe depression that can go with this, suicide attempts and completion that goes along with this. So again, another really horrible psychiatric disorder, bipolar disorder. Acute treatment, antipsychotics, things like haloperidol, as an example. But the real treatment is lithium, right? But it takes weeks before it starts to work. So acute treatment, antipsychotics, but more chronic treatment is lithium for bipolar disorder. Bulimia, again, similar to anorexia, but not the same as anorexia. Again, young women, eating disorder. This is the one where you get more of the binge purge, right? So they may eat and then they purge. They may self-induce vomiting, and they may have marks on their fingernails or on their fingers, and decreased enamel on their teeth because of the gastric acid coming up. They may abuse diuretics or things like that, or laxatives, things like this. But their weight in general is more normal to increase. They don't have the exact same really super thin look as someone with anorexia does. Again, adolescent women more commonly. Catatonia, not very exciting, right? That's it. That's catatonia, all right? So they're rigid. They're not talking. They're not doing much. They're not giving you much history or things like that. Obviously, they can get dehydrated. They can get light imbalance and things like that. We're going to talk about neuroleptic malignant syndrome in a minute. Those patients are sick, febrile, rigid, looking really, really sick. They're not just sitting there staring out and not talking to you, all right? A little hint for catatonia. I actually used this once. I was taught this as a medical student, and it's the only time I actually really used it that it worked, but it was so cool. I had somebody who came in a catatonic state. People were trying to get history from them. No go. Nothing was happening. Weren't going to say anything, that sort of thing. And the thing I remember being taught was to try to whisper to them. I don't know why, but it worked. I walked over to the guy and I just whispered, "Hi, I'm Dr. Sokolov, and are you doing okay? And, are you hungry?" And it was like, little nod, and next thing you knew, the guy was there with the tray, totally eating and moving. It was like, oh, I looked like a superstar, all right? Like once out of 25 years, all right? So you got to give me a break here, all right? I'm taking the credit on the once. But it's pretty cool. You got to try it. So if anybody here ever done that? How'd it work? All right, it's a couple. Okay, it's not just me. I'm not lying. Okay, there's a couple other friends here that have done this too. So, but give it a try for catatonia. Maybe it's going to work. Delirium versus dementia. Right? Delirium is altered mental status. That's what we think of as altered mental status. Right? They're confused, they're altered, they're disoriented, waxing and waning. Do your workup to rule out all the things that cause altered mental status. Dementia is more impaired cognitive function, right? This is like memory and judgment and things like that. They're awake and they're talking to you and that sort of thing, but they're having impaired memory or judgment, things that you see with, typical dementia. Alzheimer's over 65, right with dementia, very common cause. They get those beta amyloid plaques and those neurofibrillatory tangles that go on in the brain. Multi-infarct dementia is just like it says, bunch of infarcts, now you have dementia. And of course, even somebody with chronic dementia, when they come in altered, it's still, we got to rule out the organic stuff, rule out the medical, their urosepsis and all the other things. Okay, depression, again, this, I won't spend a lot of time on it. Loss of interest, loss of appetite, loss of energy, decreased sleep, psychomotor retardation, so everything's kind of flat and moving slowly, flat affect, obviously at risk for depression and things like that. At risk for suicidation as well. Somatoform disorders. Okay, let's go through these. Somatization. This is somebody who comes into your ED, they have multiple repetitive concerns over and over. They come back over and over. Or they got lots of concerns. Oh, this is bothering me. Oh, and this thing is bothering me. And that thing hurts. And this thing aches. And this is going on and that sort of thing. And you find yourself wanting to say, you don't say it, but you think it sometimes, you think like, you don't understand. It is one chief complaint per visit, okay? You get one. Now you're going to give me your one and then go back out and re-register, all right, that sort of thing. So, you find yourself thinking that way, think about somatization. There may be multiple things going on there. Hypochondriasis, it's similar, but it's not the same. These are patients who are really preoccupied that they have an illness. They are sure they have an illness. They have a disorder, they have a disease, no one's just found it yet. If only you did the right test, you'd figure it out. I'm sure, they're very preoccupied that they are sick. Conversion reactions, to me, honestly, is probably the coolest and most amazing thing in all of medicine. I don't know why. To me, it just blows me away. Blows me away. Right? So here's conversion. By the way, conversion is you have an acute neurologic deficit for which there is no explanation. So it's an acute neurodeficit. You're numb, you're weak, you're blind, you can't talk, whatever. It's some neurologic deficit, acute, and there's no organic explanation for it. So a 26-year-old woman, restrained driver in a car accident, rear-ended 5 miles per hour. Scratch on the bumper. That's it. Paramedics bring her in, full C-spine precautions on a backboard because they say she can't move or feel her legs. You're like, come on, how could that even be possible, right? So you go over, you introduce yourself, you examine her, you check her arms. Can you squeeze my hands? Yeah, squeeze my hands. You feel this? You feel that? Yep, I feel everything. You go down to their legs. Can you move your legs? No. Okay, do you feel your legs? You feel this? No, on their legs. Do you feel that? No. Do you feel this, right? Then you're like getting out the reflex hammers and like the 18-gauge needles, and you're like doing this stuff all over, and like blood's dripping off the sheets, and they're still not moving their legs. It's like, whoa. These folks are not faking, okay? They are not trying to pull one over on you. They don't have secondary gain. They're not faking. They just have some dissociation up at the brain where they do not feel this stuff, okay? And we don't know how to explain it. Totally bizarre. If you MRI'd them from top to bottom, normal, everything's normal, okay? That's conversion reaction. It's an acute, dramatic neurologic deficit for which there is no neurologic explanation. So one thing that you want to not do is get mad at them, blame them, yell at them, tell them they're fakers, because they're not. They can't help it. They're not faking it. It's what they've got. What you can do is reassurance. So sometimes they have a history of this already, and so they've had it before, and you can say, oh, I know you've had this before. I think this is what you're having again. I don't see anything, that I think is wrong with your spinal cord. I want to reassure you. Good word, reassure. I want to reassure you about this, and I'm going to come back and I'm going to check on you in about 10 or 15 minutes. And we find that oftentimes when we do that, you start to feel a little bit better. But I'm going to come back and check. And you come back 10 or 15 minutes later, and all of a sudden they got like the toe flicker. That thing's going. You say, that's great. I'm glad you're doing better. It's like we thought, but I know it's going to take a little more time. I'll come back in another 15 minutes. I'm going to check on you again. And you come back again, and all of a sudden, the next thing you know, they're walking at the bedside, and you avoided the MRI, okay? So give it a try. Don't yell at them. Don't be mad at them. Try to reassure them. Give it a little bit of time. Be supportive, and see how that works. The other thing that's really weird about conversion reactions, by the way, is that they have this inappropriate indifference. They don't seem to care that they're paralyzed, right? So like if I'm in a car accident and I can't move my legs when the paramedics pull me out of there, I'm going to be freaking out, okay? I'm going to tell you that right now. I'm thinking about, oh my God, can I work, and my wife, and my kids, and my this, and right, all this sort of, I'm going to be freaking out. They're like, so you can't move your legs at all? Nothing at all? Yeah, pretty much, can't move my legs. Nope, can't move them, doc. Yep, go check them out. So they're basically surprisingly indifferent to this, right? It's like, shouldn't you be freaked out? But they're not freaked out. They have this inappropriate indifference. They're kind of their brain is just kind of disconnected and kind of checked out from is what's really going on there. Okay. By the way, what about when somebody tells you, I'm blind, I can't see anything, doctor? What's the test that you can do to see whether they can really see? And don't say visual acuity. Come on now. All right, I'm going for something more than visual acuity. How do you do it? What was it? Yeah, opticokinetic nystagmus. That's exactly right. So you either take the black and white stripe thing or the spinning black and white wheel, and you spin that in front of them, black, white, black, white, black, white, and they will get the nystagmus. Anybody will. Anybody who's got from eye to brain, if it's normal there, you're going to get it. You can't suppress it. You can try your hardest not to, it doesn't work, okay? So that opticokinetic nystagmus is something you cannot suppress. So somebody's like blind and staring, get the little thing, or take every other medication label off, and go like this. We all have our little tricks, those sort of things you can try to do. All right. What else we got? Malingering. Okay, these are fakers. You can get mad at them. Just kidding. These are fakers. These are people who actually are malingering. They have secondary gain. They're exaggerating their symptoms. There's something they want. I don't know. It's the work note or the opiates or they have the positive attorney sign, right? I was in a car accident 3 days ago. I saw my attorney 3 hours ago, and now I'm here to see you, all right? That sort of thing. I had a guy I saw with shoulder pain in our fast track many years ago, big, buff, muscular guy, and he's like, oh, my shoulder hurts, doc, can't move it. I'm like, oh, let me examine you. Like, he's in a gown. Show me a little bit, anything. Oh, nothing. A flicker, throw me a bone, anything, come on, anything, nothing. He's not moving this thing. He's like 3 times my size, all right? Like, seriously, what's going on? Then he starts asking me for a ton of opiates. We know how this story goes. And when I very politely declined, he got really pissed off at me, ripped off his gown, threw it on the floor, and said, you are the worst doctor I've ever met. And I'm like, but you're better, okay, because you're moving your shoulder now. So anyway, so that's malingering. Those are actual fakers. Munchausen syndrome is where people fake medical illness in themselves. They make themselves medically ill. They self-inject with insulin with no C-peptide. Remember that one? Okay? They self-inject with insulin, or they do something to make themselves sick, because what they want is hospitalization, tests, procedures. They want medical attention. They want more and more stuff. This is the person who's had multiple bowel obstruction surgeries, and it's got scars everywhere, and it's like, yeah, I want another one. Yep, nope, just fix it. Go in there and do that. And you're like, are you kidding? Like, no way. This is the person when, like, you're like, are you sure this is the worst headache of your life? They're like, yep, you got it, bring it on, that sort of thing, right? Okay, so that's Munchausen syndrome. And then, and by the way, it's common in healthcare workers, so they know how to fake illness. They're pretty good at it, all right? Munchausen's by proxy is child abuse. It's a parent causing disease in their child so that they get medical attention, right? The kid always desats when no one else is in the room. But when everyone's in the room, the kid never desats or something like that, right? Kid goes bad, that sort of thing. Okay, neuroleptics, real quick reminder. Lots of symptoms you get. You get extrapyramidal things like akathisias, dystonia, tardive dyskinesias, things like that. Anticholinergic symptoms from them. Alpha blockade, which means orthostatic hypotension when you're standing up, orthostatic hypotension and syncope. And they all give you QT prolongation. Some are worse than others, but they all do it, right? Neuroleptic malignant syndrome, I promised I'd tell you about this. Somebody's on an antipsychotic, usually within a couple of weeks of starting. So they just got started on their antipsychotic, and now they are really, really sick in front of you. And they have fever, F-E-V-E-R, fever, encephalopathy, so they're altered, vital sign instability, hypertensive, hypotensive, tachycardic, things like that, elevated CPK, so some rhabdo going on, they're really, really sick, and R is rigidity, and it's lead pipe rigidity. It's not just like, oh, a little bit of increased tone. It's like they are stiff like a lead pipe, and they are not moving. So neuroleptic malignant syndrome, they are sick patients, they're altered, they're febrile, they're stiff like a rock, that sort of thing. That's NMS. Treatment for this, fluids, benzodiazepines, and you can also consider dantrolene or bromocriptine, right? Things that you can use for neuroleptic malignant syndrome. But starting off, some fluids and benzos. Serotonin syndrome is similar, but it's not the same, okay? This is not somebody who's been on antipsychotic for a couple of weeks. This is somebody who's been on some sort of medications that has serotonergic activity, right? Like an SSRI or other medicines, usually combinations of medicines with serotonin activity. And they look similar to NMS, but not the same. They're also altered, so they have altered mental status. They've got autonomic instability, just like the NMS person, right? Fever, blood pressure, up and down, things like that. So they got the altered, they got the autonomic instability, they got all that same stuff, but their neuromuscular stuff is more irritability. It's more twitchy, jerky, like myoclonus, hyperreflexia, tremor, twitchy, jerky stuff, not rigid like a lead pipe, twitchy, jerky sort of stuff, all right? That's one of the ways that you can tell them apart, as well as the medicines that they're on. So the altered, autonomic instability, but neuromuscular irritability, not the rigidity. Okay, treating for them, again, fluids, lots of benzos, and fluids are the most important thing. You can use some serotonin blockers like chlorpromazine or ciprofloxacin. Schizophrenia, I'm going to breeze through pretty quickly because I think you know about this. Young patients, oftentimes homeless, one of the psychotic disorders, delusions, auditory hallucinations, disorganized thought process, things like that. Suicide, just a few facts that women attempt more often, men actually complete more often. Obviously, depression is a risk factor. Also, drugs and alcohol, previous attempts, living alone. Widowed men at greatest risk. If you're an elderly man, just lost your wife, high risk of suicide. And suicides occur more often in the spring than in any of the other seasons. Involuntary holds, I think every state is a little different in those laws and what they call it, but the same concepts. Danger to self, danger to others, or gravely disabled. So not just psychotic, but danger to self, danger to others, or gravely disabled. Those are patients that need to be put on involuntary hold. Little trivia, DTs, as you know, is alcohol withdrawal, but it's the severe end of alcohol withdrawal. You start with a little, alcohol withdrawal seizures, well, shakes first, alcohol withdrawal seizures, then alcoholic hallucinosis, and then you get the delirium tremens where you actually are confused, disoriented, very, very sick, fluids, benzos, oftentimes needing the ICU, DTs, right? Parkinsonism, a few things to remind you of what they can get. they can get difficulty with their balance, and they get this gait, this kind of shuffling, short-stepped gait, kind of shuffling gait. They may have masked faces, look depressed, and pill rolling, sort of tremor. Kind of that sort of look, all right? They get increased tone, they're rigid, but they have cogwheel rigidity. Their arm isn't just increased tone, it's like the little cogwheel things, right? Cogwheel rigidity when you're looking at their tone. That's with Parkinsonism. ADHD, to make it simple, is basically too much motor activity relative to your developmental age, okay? So more activity, motor activity out of proportion to their appropriate developmental age. They treat it with things like methylphenidate, dexedrine. Tourette syndrome, those are the folks who have lots of tics, vocal tics, motor tics. They can do the thing where they blurt out curse words. Everyone talks about that too, although they certainly don't all do that. It can be really disturbing for them. Night terrors versus nightmares, really quickly. Nightmare, little kid Johnny, right? Wakes up in the middle of the night screaming, wow, there's a monster, there's this, I had a bad dream, and you're looking under the bed, and you're looking in the closet, and you have to do that forever. Like for the next week, you have to check Johnny's closet, right? Bad nightmare. Night terrors is different. Younger patients who kind of wake up, they kind of sit up, maybe in the middle of the night, and they start screaming, wah, 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 or things like this, or maybe moving around, maybe even walking, but they don't really seem like they're awake, if that makes sense. They're not like talking to you, that sort of thing. It lasts 15 minutes, and then it goes away. Then they go back to sleep. All right? And, so they're like looking really horrible, and then they go back to sleep. And they don't remember it. So the next morning, you're asking them, like, hey, Damien, like Johnny, like, what happened when your head was spinning around last night? And they're like, what are you talking about, Dad? I'm fine. I don't remember anything from last night. So they don't remember it at all. Different than a nightmare. As a parent, they tell you, don't wake them up. So when your kid is sitting up, screaming, yelling, walking, and vomiting green pea stuff, all right, you're supposed to not wake him up and just leave him be and let him go back to sleep. So you can try it. Good luck with that. But anyway, that's what you're supposed to do. Just keep them safe. Okay. Pica is basically when people just ingest non-food substances, right? Baking soda, chalk, clay, dirt, cigarette butts, and more common in pregnancy. Okay. Went over a little bit. Thanks for your attention. We'll see you at the review session.